lecture. As you know, in this series, we like to showcase the research that we have at the university, and we like to range across different disciplines, and we like to introduce some of our star researchers to you and to the wider public. So many thanks for being here. It's such a pleasure today to introduce David Matheson. What I'll do now is I'll say a few words of introduction about David, then I'll hand over to David for today's presentation. And at the end, we'll have the opportunity for any questions, any comments. We really welcome those kinds of responses. So David himself, after his first degree in maths and physics, trained as a teacher, taught in the secondary schools in Scotland, Spain and Switzerland, and then returned to Scotland to teach science and physics in a secondary school in an area of multiple deprivation. During this time, David undertook Masters of Education in Comparative and Adult Education at the University of Glasgow. And following this, David completed a PhD on post-16 education in all its forms in the French-speaking part of Switzerland. David then joined the University of Wolverhampton in 2017. In the course of his academic career, David's moved across and between domains and subjects. His work has as learning and teaching a central concern and a unifying thread across his research. This even applies to his work on the Stampede trial, which he'll talk about today, and in his role as a patient advocate for Prostate Cancer UK and for prostate cancer research, where his function is to educate others on the patient perspective. Here, I'll add that David is a cancer survivor himself and has written very eloquently about his experience in our Wolverhampton Humans series. I'll add that link into the chat in a minute. In addition, David has written and presented on all sorts of things to do with education, especially over the last few years, when his focus has been on medical healthcare education and the experience of patients and those who support them. He's very active in issues around prostate cancer, both from a sociological and a clinical perspective. David's current research interests include what it means to be well for a person with prostate cancer, the lived experience during COVID of the specialist nurses and volunteer peer supporters at Prostate Cancer UK, and the examining and developing strategies to counter racist behaviour towards health and social care staff in a rural part of England. With that, if I may, I'll hand over to David.
Thank you very much. Thank you very much, Ben. And now I'll try and work out how to share my screen.
Yeah, we can see it, David.
Excellent, excellent. Righty-ho. Let me just get started then. Okay, thank you very much for that kind introduction, Ben. What I'm going to be looking at today is the idea of what does it mean to be well for a person with prostate cancer. Now, when you hear terms like well and cancer, they maybe don't fit together quite as you might think, but because they seem to stand in contrast. How can you be well and have cancer? Well, this is something I want to explore with you for the next little while. The opening thoughts, I like to think, are you well? Well, if you're well, how do you measure it? You're well with respect to what? You know, what is your notion of wellness? And if you think when people ask you, how are you? If you say, I'm well, what do you mean? What do they understand? And this is kind of very much, it's like a contested concept. You know, we use these terms, we bandy them about, like well and unwell and whatever. We talk about health and ill health. Trying to think, what does it actually mean to yourself? What does it mean to somebody, for example, with a physical handicap, to a disabled person of some sort? If you have a disablement, can you be well? Well, I would suggest yes, you're well with respect to yourself, or not well with respect to yourself. But let's move on a bit from that. Here's a little outline of what we're going to do. Now, this is work that myself and Dr. Catherine Matheson Money have carried out over the last couple of years. I'm going to look a bit at the background. I'm going to talk a bit about prostate and cancer, about what the prostate is and so on. But this notion of measuring wellness and how it's done within the world of cancer, look a bit at what we did and then what we found. And the last bit, which I haven't mentioned there, will be a take-home message. So, in the background, one day in July 2012, there was I, ordinary bloke in his 50s, This was after I'd been to a cartooning workshop and discovered that being bald, bearded and having glasses is a caricaturist dream. So I drew caricatures of myself. So there I was, just going through life as normal. Certain things were going awry. Now, being a man, I chose to do nothing about it. Catherine, being a woman, and the most significant woman in my life, pressed me to actually get myself tended to, and no, I'm fine, I'm just getting old. He said in his mid-50s, I'm now considerably older than that. And on that day, prostate cancer was found. I went to my GP, she examined me, she eventually took some blood. I was sent to get further biopsy, and I was found to have prostate cancer. And at that point, it became part of the wallpaper of our lives. This is the thing about cancer. Once it's in your life, it never leaves, because you never know when it's going to come back, for one thing. We had to adjust to a new reality. And part of that reality included trying to redefine what it meant to be well. Now, I have to tell you, although I got a 2-week referral to the hospital and was found to have locally advanced prostate cancer, I felt fine. Just had to go to the loo rather a lot, but I put it down to a dodgy prostate, having had prostatitis in my 30s. I thought it'd just come back. Now, eventually, through the work that we did with Prostate Cancer UK, with prostate cancer research, and me eventually becoming a patient representative in the Stampede trial, we encountered an awful lot of other people who are in the cancer club, either on their own part because they've got prostate cancer, have had it, or because they're close to somebody who does. And this got us wondering, well, we'd kind of worked out what well meant to us. What did well mean to other people? And this is what spurred us to do our research. So with this in mind, the prostate. Prostate is a wonderfully misunderstood bit of anatomy. Prostate Cancer UK did a survey a few years ago where the researchers walked up to individuals in the street and asked them where the prostate was. I hope they were well paid for doing this, but the answers they got were absolutely amazing. Everybody knew somebody had a dodgy prostate. Quite a lot of them didn't actually know that the prostate is only part of the male reproductive system. And they're asked to point out where it was in the body. And roughly about a third of the respondents said it was in the chest. Well, it's, first of all, only people born male have a prostate. Some intersex people have one. Intersex individuals have a variety of, let's say, mixed male and female sexual characteristics. Trans women still have a prostate unless they've had it removed as a result of prostate cancer, because the prostate is not removed in gender reassignment surgery. What the prostate does, it provides fluid for ejaculation, and Cancer Research UK provided this very helpful little diagram. You can see the prostate sits underneath the bladder. If it starts to swell up for any reason, then it can block the flow of urine. It can do all sorts of awkward little things, but having difficulty peeing is often the first sign that something's amiss. So prostate cancer is the most commonly diagnosed cancer in the UK, and it's one of the most common in the world. In the UK, 1 in 8 men will develop it over the course of their lifetime. 1 in 4 men of Black African or African Caribbean heritage will develop it. Nobody knows why there's the difference. There have been various studies looking at genetic markers, diet, lifestyle, and so on, and it's still a mystery. You know, what is it between people of Black African heritage or African Caribbean heritage, which means they're more prone to prostate cancer? Risk increases with age, and the risk more than doubles if you have a first-degree relative with the disease. So our son, for example, instead of having a 1 in 8 chance of developing it, has 5 out of 16 chances. It goes 2.5 times up. The risk can also increase if you have a sister or mother who's been diagnosed with breast cancer. I say it may increase because it depends on the kind of breast cancer. There are multiple varieties, but it does tend to be worse if they've been diagnosed before the age of 60. Around 52,000 men are diagnosed each year. This is rather a lot. There's about 400,000 of them in the UK living with or after the disease. And 95%, more than 95% will survive the cancer for a year or more than 85% for 5 years or more, nearly 80% for 10 years or more, but around 12,000 die each year. Now, the survival rate is going to depend how early the cancer is caught. The earlier it's caught, the better the survival rates. There's usually no symptoms of prostate cancer. I was fortunate. I had various symptoms. That's what eventually pushed Catherine to push me to get checked, and my cancer was found. But most prostate problems aren't cancer. There could be prostatitis. That's a generalized swelling of the prostate. It can be painful. It can impede urine flow. Enlarged prostate, very common among older guys. Technically, it's termed benign hyperplasia of the prostate. It just swells up. It starts to block the urethra a bit.
To spread, to extend, to diffuse.
Somebody's got their microphone on. It's absolutely fine. It's just a bit minorly distracting, I dare say. So enlarged prostate can block the flow of urine and so on, but it's not prostate cancer. A urinary tract infection can give prostate problems as well. So most of the problems are not, most prostate problems are not cancer, but some are. Now, the kind of investigations that you get, PSA, prostate-specific antigen, it doesn't say whether somebody has prostate cancer. It's indicative, if the level has gone up, that there might be a problem with the prostate. Digital rectal examination, this is the classic thing where the doctor, generally a doctor, occasionally a nurse, will put their fingers, suitably gloved, into the man's rectum and feel the prostate. Problem is you can only feel part of it, you can't reach the other bits. But again, this is something that's indicative. If the PSA is up, if they feel lumps and bumps on the prostate, then as with me, that's a two-week referral. A biopsy is definitive. Biopsy may find, if it finds cancer, you definitely have it. If it doesn't find cancer, it might not have stabbed in the right place. There's also MRIs and other scans that can be done. These are all sorts of things that you go through. I've been through the whole panoply myself. Now, treatments, there's a raft of them. Surgery for very early stage is one of the more common. There's different sorts of radiotherapy. There's standard external beam radiotherapy where you lie underneath a linear accelerator and you feel absolutely nothing in general. You may have things afterwards because if you're irradiating a prostate, it can give you diarrhea and so on. But at the time, you feel nothing at all. Different sorts of internal radiotherapy as well. I had a thing known as high dose rate brachytherapy, where a strong radioactive source was inserted through my perineum. That's this bit of skin between the testicles and the anus, inserted at 16 different points to irradiate my prostate. I was under a general anaesthetic, so I remember nothing of it. Hormone deprivation therapy, often referred to as hormone therapy, but actually it's not. What this does is effectively chemically castrate the person that's having it. I had 6 months of this. 3 months before I had my 2 radiotherapies, 3 months afterwards, I was told by my consultant it would be like having a menopause. And I can assure you, having compared what I had with several menopausal women, it sounded pretty similar. Chemotherapy, there's lots of chemotherapy agents out there. This is just part of the list. There's also things like cryotherapy, where there's an attempt to freeze the prostate. There's HIFU, which is high frequency ultrasound, which basically tries to effectively cook the prostate. But thing to bear in mind, despite all this panoply of possible treatments, the appropriate treatments depend on how advanced the disease is. So not all treatments are possible or advisable at all different stages. All the treatments have side effects. They can be short-lived, they can be lifelong, some are immediate, some take a long time to occur. Very much variable, varies also from person to person. They depend on the treatment, they depend on its duration. Now, the most common side effect, problems around urination, which is a bit ironical considering that this is often the first thing that gets folk to get themselves checked. It can be short-lived, it can be longer-lived. With myself, I had some short-term problems with the urination, which was getting a bit more frequent. It should have been like 15 times a night. You can have problems around sexual function. The nerves that serve the penis that allow a man to have an erection pass through the prostate. Anything you do to the prostate can impact on these. So a man who has his prostate removed, the nerves can be damaged, parts of the nerves might be removed. The radiotherapies that I had, people having the same sort of treatments as me had, these can affect the nerves. Sexual function is very frequently impacted upon. In fact, I think it's reckoned that of the men who have the prostate removed, about over 90% have problems with sexual function, at least initially. Some never recover it. Bowel problems are very common. diarrhea, bleeding from the rear, and so on. Fatigue is a very common thing. This is one thing that I have noticed isn't talked about anywhere near as much as perhaps it should be. It's a side effect of simply having the disease. It's also an effect from radiotherapies, which can leave you tired out. And the hormone deprivation therapy can also lead to emotional fragility. I mentioned the menopausal symptoms. Part of this is emotional fragility. When I was on the hormone deprivation therapy, I could burst into tears at the drop of a hat. It was really quite phenomenal. You could say hello to me, start weeping all over the place. Hot flushes are very common. They're really quite debilitating as well. Osteoporosis, the hormone deprivation for long enough, the bone structure can start to weaken. And in exactly the same way as a postmenopausal woman can start to have osteoporosis, a man or trans woman on long-term hormone deprivation therapy can get it as well. But gynecomastia, this is breast development. This is where the breast tissue actually starts to develop in pretty much the same way as it would in an adolescent girl. Except the men who have this tend to find it very painful. It's also quite an assault on their sense of being a man. But the pain is a big thing. And there's a whole lot more. I think with my own thing, I counted something like 16 different side effects, none of which were fun. And the other thing, of course, is ongoing anxiety at every blood test. Within the world of cancer, this is often referred to as scanxiety. It's easier to see than to read. And it's this tension that you have every time you have a blood test, every time you have a scan, you're waiting for the result, you just don't know what's going to happen. And it gets worse if you've relapsed. And because every time if you never relapse, you can reassure yourself that you're away from it forever. Relapse once, you expect you're going to relapse twice. The tension just builds up and it lives with you like you're under a cloud. So how do you measure wellness? This lot have attempted, European Organisation for Research and Treatment of Cancer. They developed a whole load of questionnaires. We have a general questionnaire, quality of life questionnaire, QLQ 30 questions long, hence the QLQ 30, and one of 25 questions specifically for prostate cancer. The idea being that everybody who's having the questionnaire will do the general one first, then they do the prostate one. These are entirely quantitative, so you're asked to give a score. Let me give you an example. During the past week, have you had to frequently urinate during the day? Not at all, a little, quite a bit, a lot. Have you had to urinate frequently at night? And again, same thing to choose from. What it doesn't ask was, how do you feel about it? How much did this disturb you? Now, urinating frequently during the day may be a big drag for you, depending what you're doing, depending where you are, depending what frequent means to you. During the night, you might get up 5 times and go back to sleep immediately. If you're waking up, go immediately to the toilet, come back, lay down, relax, out like a light. You might wake up in the following morning very refreshed. On the other hand, you might only go once. It might be you're not actually urinating frequently. It's went once. Is that frequent? I don't think so. But that could wreck your entire night's sleep. And this is something which I would suggest these questionnaires don't quite deal with. They don't ask how are you actually living the disease. You don't live with the disease. As I mentioned earlier, it's really part of the wallpaper of life. So living the disease, what impact is this aspect of the disease, or it's often the impact of the treatment, what impact is that having on your life? Is it livable? Is it not livable? What we did, we sent out a survey and we posted this onto various social media. And we just wanted to know, what does it mean to be well? So we're looking for people, looked for people, and the thing's still open, by the way, who either have or have had prostate cancer or close to somebody who's has had prostate cancer. And this is what we found. 77 responses came to the survey. 52 were from men who have or have had prostate cancer, and 25 were from persons close to a prostate cancer patient. We did 11 telephone interviews, 10 with patients, only one with a partner. As I say, this is still open, so if you either have or have had prostate cancer or close to someone with it, then please feel free to do the survey. I mentioned earlier that the frequency of prostate cancer goes up with age. Now, you can see that our respondents, age at first diagnosis, they're in a fairly tight clump between 55 and 69. Now, those under 55, prostate cancer is much rarer. It also tends to be much more severe. And one individual that I interviewed had been diagnosed at the age of 47, and the whole thing had been a disaster. Any notion of wellness to him was a memory rather than part of his ongoing life. He couldn't see any way in which he could actually be well, unless, as he put it at one point, he had a body transplant. The older ones are much more likely to have the disease. They're also much less likely to be surfing the web. They may never have come across our survey, and it'd be good to actually expand on basically on everybody. Now you can see how they were spread out. In terms of where they were at with the disease, well, 54% of the patients and 28% of those known partners or whatever did the survey were early stage, which means that their tumour was on one side of the prostate only, and it hadn't broken out of the prostate. The prostate sits inside a sort of capsule. And if you're locally advanced, which is what I was at diagnosis, it's begun to break out of the capsule, and it might have appeared in a lymph node or two. More advanced is spread to other parts of the body. And of course, you expect that those who've been patients are likely to know, those who are partners, friends, etc., may not necessarily know, and 2 of our respondents there didn't know. Now, in terms of treatments, you can see there is a raft of combinations that can be had. Active surveillance and watchful waiting are ways of actually postponing radical treatment. Radical treatment is when you try to deal with the disease as a disease. So in active surveillance, the way it's done within the UK in general means that the individual will have blood taken from them every 6 months or every year just to check what PSA level is and see, is it changing, is it staying the same? They may have a biopsy, they may have an MRI scan. Watchful waiting, they tend more just to have the blood taken once a year or so. Cryotherapy, I mentioned, is it trying to freeze the prostate, and high frequency ultrasound. But you can see there's all sorts of combinations which occur. And this is what people had as their initial treatment. What they have as later treatments might be different. My initial treatment was high dose rate brachytherapy, external beam radiotherapy, and hormone deprivation therapy. Since then, I've had 2 separate lots of external beam radiotherapy because I've relapsed twice. In terms of mental health, I think being told you've got cancer is not going to be the brightest day of your week. That's to put it mildly. Even if you're pretty sure before you get told that you actually have it. I was quite confident that because my GP had found a rough lump in my prostate, because my PSA was up, not massively, but it was up well beyond the reference level, I was resigned to the fact that I had prostate cancer. Now that might be a reflection of my upbringing. My father was almost like the cliche doomed Scotsman. Those of you who've seen Dad's Army, you might remember the Scottish sergeant who was doomed. Well, my father was exactly like that, and it rubs off. So fatalistic. Absolutely resigned to it. Catherine, on the other hand, wasn't. So mentally affected the pair of us a bit differently. Now, out of our survey, 18 of the patients said they were depressed, sometimes to the point of despair. And as one fellow put it, there are often times when I wish my life to end, as it does not offer any prospect of contentment or convenience, as others appear to enjoy. This fellow did an interview with me, and it was harrowing. It was tough for him. It was really tough for me, because actually, in lots of respects, in comparison to what others have been through, mine has been very easy. It has, definitely. Having the cancer is not a great positive in my life, although I have been able to derive some benefits and interest from it, like being able to investigate it. But in comparison to this poor lad, his was just awful. That he couldn't leave the house at all without leaking urine. And one thing which is really horrible to have is incontinence. One of the things which I had, which eventually pushed Catherine to push me to go and get checked out, was I was leaking. And this is a horrible place to be. You change your clothes into work with you and clean yourself 3 times a day. Awful. This poor guy had it all the time. 9 out of the 52 were anxious. And this anxiety of the cancer returning, as this guy put it, the worry of the cancer returning will always be with me till I die. He hadn't had a relapse, but his fear was that he would. The fear is it comes back worse. Now, in my case, it just came back different. But there's generally fear. If it's managed to take itself out of the prostate, into somewhere else, where's it going to next? 3 out of the 52 are actually quite stoic. They just accept it's a part of life, just go on with it. 5 out of the 52 reported an improvement in their mental health. And that can be quite surprising. But sometimes when an individual suddenly is face to face with their mortality, which is what cancer does to you, really quite abruptly, then they begin to feel that they better make the most of the days that they have, because your days are numbered. 17 reported no change in their mental health. Now, it's not surprising that the reported mental health is directly related to the response to treatment and to any positive life changes that are consequent to the disease and its treatment. So the individuals who thought, I've got to do something, get out there, stop having the bucket list you just keep adding things to, start doing it. But it's also related to a willingness to share. Now, one of the problems about surveys is you can only ever trust what people tell you. And we then have to interpret on the basis of what they've said, what is it they actually mean? And it's fairly likely that not all of these men were really willing to open up about this part of their mental health. This is quite a sensitive area. Now, the partners, etc., I say partners, etc., because there were daughters, friends, wives, other partners, male partners, female partners, so on. 8 out of the 25 reported that their loved one was depressed or anxious. Quick temper was also mentioned. Now, interestingly, none of them, the patients, mentioned quick temper. Emotional fragility featured a little bit with them, but not to a great deal. It was the partners, etc., that talked about it. One said, gets angry quickly, some depression, and no patience. Only 3 of them mentioned emotionality. Now, if you think about almost the caricatural man as seen in our society is an individual who is presented as strong, doesn't weep without great difficulty. This is not the same. I mean, obviously, this is not universal across males in different cultures, but within UK cultures, there's a sense of stoicism which runs through. So emotionality can be suppressed. 2 out of the 25 reported an improvement in their partner, etc.'s mental health. 1 was reported as suicidal. This was his daughter, and she wrote about her by now late father. He frequently talked of throwing himself out of the window to kill himself. His last 6 months were utter misery, and if assisted dying had been legal, I know he would have requested it. It's quite tragic. 5 out of the 25 reported no change in the mental health. 6 were unknown. And the reported mental health can only be based on observation, clearly. Now, in the interviews, several of the patient participants referred to hiding their negative emotions from their partners. The kind of thing they would say was, I don't want to worry her too much. Or in one case, I don't want to worry him too much. But they weren't always successful at hiding it. As one wife put it, he tried to hide from me just how depressed he was, but I could see how he was suffering mentally as well as physically. What you tend to find is that those who open up to their significant other, who actually share what they're feeling, are the ones who seem to be able to cope better with what's going on. Even when it begins to decline, it's the sharing that does it. One of the problems is what they also tend to worry about then is burdening the partner. What is it to be well? As one patient said, having no specific unwellness or symptoms, being able to do whatever I usually do and want to do without concern. Not having aching joints, man boobs, sore boobs and lethargy. I mentioned the boobs before, and they tend to be painful. And as this person said, it'd be brilliant to get a full night's sleep without getting up 2 or 3 times for a pee and then sleeping fitfully. Going out without worrying where the toilets are and making sure of enough pads for the day would be great. Feeling well physically and still working as it maintains his mental health, said a partner. One individual, I don't let this be my defining moment, so to speak. Not having to not drink before car journeys, etc., and also not having back or hip pain. I mean, for me, if I were able to drink as I would like to drink, just tea, coffee, whatever, before going on car journeys, that would be great. And as an individual said, simply removing the mental prison of immobility and constant urination would be like being reborn. So far, to be well, very often not unwell. But here's one person that said, the prostate cancer has helped me prepare better for older age. One of the sad things about anonymous surveys is when you eventually interview somebody, you can't really generally relate what they've said in the questionnaire to what they say in the interview. And I don't think this fellow actually came from the interview. It'd been lovely to have actually asked what his conception of older age actually was and how the prostate cancer had helped him. But there you are. It's a life challenge that helps you actually sort of move on to the next bit of life. Be able to function as before. And here's somebody very positive. It's great to feel well despite my original diagnosis. It's allowed me to support others newly diagnosed, and my 8+ years survival is a flagship for others. This giving to others, supporting others, is a rather pivotal thing. And we find that those with the best wellness are tending to do this kind of thing. I'll say more about that in a second. And then partner saying it would be great for him to wake up feeling refreshed after a good night's sleep and feeling full of energy, instead of dragging yourself out of bed like you haven't slept at all. You know, to waking up each morning and get on with life. The implication there is not having to think about, well, when's my next scan? When's my next PSA test? Not to have these clouds hanging over you. And we have a young person in his 60s. I try to live life to the full. I'm a really positive person. The fact is diminishing wellness. Sexual difficulties are not really surprising. Erectile dysfunction, where a man has problems getting an erection, sometimes there is no sensation down there at all. Loss of libido. Now, these aren't cited by everybody, because some of those who have loss of libido, it happens in such a way that they don't have a libido and they don't care about it either. I mentioned again gynecomastia. Pain. Pain can be the result of the treatments. Pain can be the result of the cancer. It can be the result of both. One of the difficulties is that when you have the pain, you don't know what to ascribe it to. This leads to uncertainty, it leads to fear, and I mentioned anxiety. Fatigue. Fatigue is different from tiredness. When you're fatigued, you want to sleep. You sleep, you're waking up, you're just as tired as when you went to sleep. You drag yourself along. It's actually helped by exercise. The more active you are, the less you're likely to feel fatigued. Urinary issues. Urination is something that most of us don't think about until we actually have to go for a pee. When you have the urinary issues due to prostate cancer treatments, that becomes an overwhelming part of your life. Disturbed sleep is very common. It seems to be very common among people who've had radiotherapies of any sort. And I don't know of any research done in this, but certainly talking to a large number of individuals and observing the various forums that there are, that Prostate Cancer UK has and so on, you find disturbed sleep features very highly. So does loss of identity as a man. And then you get to know, what is it to be a man? Is it to have sexual function? Is it not to have large breasts or whatever? What is it in there? To be stoic, to be strong, all of these things. The identity of a man is very much a personal construct. And what leaves one man completely unfrazzled might absolutely wreck another. It's very individual. Loss of strength is very common, especially people in long-term hormone deprivation therapy. You get loss of muscle mass. You can have loss of weight, you can have gain in weight. Hormone deprivation therapy often causes you to gain weight, but not with everybody. It can go either way. And if you're feeling ill, you don't feel like eating. What maximizes wellness? Having livable symptoms, livable side effects. This is like a statement of the bleeding obvious, because if you're in chronic severe pain, it's very difficult to feel well. Positive mental attitude helps to build on this. And actually, the positive mental attitude does help to make certain symptoms, up to a certain point, it will help to make the symptoms more livable than they might otherwise be. But within that, there's restraining nostalgia for what the disease and treatment have taken away. It's very interesting in talking to individuals who are very down about their disease. They yearn for a past that's gone. There's almost like a lack of acceptance. There's a wish, it seems, to be in denial of having the disease, you know, like in the good old days I could do this, that and the other. Well, some of the things they might not be able to do is down to age. And it's an interesting difference between those who think, well, I can no longer run up a ladder the way I used to because I'm getting older, and those that say the same thing but put it down to the disease or down to the treatments. The first one is likely to be much more positive in their general outlook than the second one. Focusing on the good things and acquiring a sense of purpose with regard to the disease. It's very striking that those who did this, who looked at the disease and thought, well, got this damn disease, what can I do with it? Things like getting involved with charities, joining a support group. This is basically meeting other people, and you meet people who are newly diagnosed within a support group, so you can be the experienced one there. You might have had a completely lousy experience with the disease, but you can talk about what have you done with it, how have you dealt with it, why did you choose the kind of treatments that you chose, and so on. Doing things like awareness raising. And one thing which Catherine and I began to do with Prostate Cancer UK was to do awareness talks, where we go and we give talks, sometimes as individuals, sometimes as a duo, and we talk about the charity, we talk about the disease, and so on. And we got involved with prostate cancer research, doing various things with them, helping with looking at bids that they get and so on, and looking at documentation they produce. This helps to give a purpose to the disease, and it helps to keep you one a bit more positive. Fundraising is another. Offering peer support. This is not giving any sort of clinical help. This is listening to somebody and sharing an experience and helping them to make up their own mind about things or just unburden themselves a bit. And in short, it's finding a positive from living the disease and being able to benefit from it. Little wordles used to be things like this before they became things with words of 5 letters and 6 lines. And doing it a wordle, as it was termed at that point, with the data we've got, this is what came up with, right in the middle, life. Life is the most important thing. We get cancer, pretty big, treatment, big. There's things associated with it, PSA, how you feel, diagnosis and so on, but life is in the middle. That's the most important bit. Never end these things without a take-home message. Here's my take-home message for you. If you were born male, know what's normal for you. Men are awfully, awfully complacent. This appears to be a societal generalization across diverse cultures that men do tend to be pretty complacent about their health, but know what's normal for you in terms of whether it's erectile function, libido, peeing, whatever. Know what's normal for you and be aware of when it changes. Know your family health history. Did old Uncle Willie die of prostate cancer? Did your father, grandfather, whatever, have it? Check out your risk. Check out your cultural risk if you're of African Caribbean or Black African heritage. Then look across your family history. Has anyone in there had prostate cancer? So knowing your risk, Prostate Cancer UK have a lovely risk checking tool on their website, worth checking out. If you're born male and you're over 50 or over, get checked. The checking's dead easy. You've actually got legal right to get a PSA test. GPs might say, no, you can't have that, you've no symptoms. Well, most people with prostate cancer don't. Argue with them if necessary, demand a PSA test. If your PSA is below 3, you're fine, nothing to worry about in the PSA levels. If it's above 3, you want further examinations. It's usually a digital rectal examination they'll do first, and they'll send you for an MRI. The DRE is uncomfortable. I've had quite a lot of them. It makes you feel that you want to pee, but it's worth the bother. A couple of minutes embarrassment and awkwardness just to check if you're still going to be alive in a while. These things might save your life. And if you know somebody who's born male, and I think most of us do, encourage them to do this. So thank you very much for your attention. Any questions? I am all yours.